Hello, my name is Dr. Ayman Abdel Halim. I'm the pain and palliative consultant working at King Fahd Medical City in Riyadh, Saudi Arabia. I'm triple board certified in anesthesia, pain management, and palliative care. We're going to give you a short presentation about headaches. Headaches are one of the most common problems presented to physicians. They are painful, debilitating, and important cause of absence from work or school, and a substantial burden on society. 40% of the adult population experiences headache at least once per year. Primary headaches constitutes 90% of cases. Primary headaches are the headaches without a cause. Sometimes we call it idiopathic. The pathophysiology of primary headache is so important to understand. Basically, there are three elements in this headache. Number one, there's an element of inflammation. Number two, there's an element of vasodilatation. And number three, there's an element of myofascial pain. If you understand the concept, you'll be able to give the patient the right treatment for his case. Sometimes the inflammation predominates. We're talking about trigeminal nerve inflammation. Sometimes the vasodilatation, the vascular part predominates. Sometimes it's the muscles. These are the commonest causes of headaches. As we talked about, primary headaches constitutes 90% of all types of headaches. The most important of which is tension headache, followed by migraine. And then you will have these rare conditions such as idiopathic stabbing, exertional, and cluster. We cannot, overlook the secondary headaches, which constitutes around 10% only, but they are pretty serious, such as systemic infection, head injuries, subarachnoid hemorrhage, or brain tumor. Like we talked about in the musculoskeletal presentation, there are red flags for headaches. For example, worst headache ever, first severe headache, subacute worsening over days or weeks, abnormal neurologic examination, fever or unexplained systemic signs, vomiting that precedes the headache, pain induced by bending, lifting, or cough, known systemic illness, pain that disturbs the sleep, onset after age of 55. I'm talking about these serious signs in detail because you need to identify these because you might miss an emergency here. If you have any of these conditions, you might want to send the patient to the ER to at least get a CT scan to see what's going on with their head. We're using nowadays the International Classification of Headache Disorders, the third edition, ICHD-3. And as you see, they have a diagnosis of number one, migraine, tension headache, trigeminal autonomic cephalgias, like cluster headaches, other primary headache disorders. Headache, so the first four are the primary types of headache. Then you will have the secondary, starting from number 5. Headache attributed to a trauma or injury. We see this a lot. Patients that get, for example, a motor vehicle accident or whatever, they get these continuous headaches. Headache could be also related to cranial or cervical vascular disorder. So basically, we have other types of headache, like headache attributed to non-vascular structures, headache related to substance abuse or withdrawal, headache attributed to infection, which is pretty serious, headache related to a disorder of homeostasis, headache or facial pain attributed to disorder of cranium, neck, eyes, ears, or nose, and so forth. Headache attributed to psychiatric disorders, painful cranial neuropathies, such as trigeminal neuralgia, and other types of headache disorders. The management, basically the same as we stated in the musculoskeletal presentation. 5 things: behavioral, like stress reduction, meditation, and other behavioral therapies like cognitive behavioral therapy, or physical therapy in treating myofascial component of the pain. Pharmacological, we have a lot of medications for treatment of headaches. Sometimes also they benefit from injections, and in certain situations they need surgical evaluation. So these are just examples of behavioral therapies: biofeedback, relaxation, and cognitive behavioral therapy. Physical therapy such as acupressure, dry needling, osteopathic techniques. Biofeedback is a common technique used in tension headaches and migraines. Basically, the patient gets aware about his physiological parameters in his body, such as blood pressure, heart rate, muscle tension, and so forth. And through this feedback, he's able to deeply breathe and, can do a lot of relaxation techniques to reduce the amount of headache that he has. Cognitive behavioral therapy is another way to treat headache. In this situation, the basic core of the treatments is to change the thoughts and restructure them in the patient head, basically, which will lead to change in emotion and behavior. Nowadays, we have another technique called acceptance and commitment therapy, or we call it sometimes ACT. And this basically starts with acceptance of the current condition and mindfulness of the problem. And through this, the patient is able to change his values and help his coping skills with the pain problem. Acupressure point is a very ancient kind of therapy. Dates back to maybe 2,000-3,000 years ago. And I use this all the time with my patients. I teach them the main points they need to press on to help their headaches. Like, as you see in this picture, large intestine 4, or the third eye point, or stomach 3, or gallbladder 20, all these points, or liver 3. I use all of these points to help the patient can treat himself while he's at home. Osteopathic techniques have been shown to be very helpful with headaches. This is one of the most famous techniques they do, the osteopath. They release this muscle in the back of your neck, which is called the obliquus inferior, which basically pushing on the greater occipital nerve and all kind of nervous structures that goes to your head. The commonest type of primary headaches are migraine and tension headaches. As you can see, the migraineurs usually suffer from a unilateral type of headache, while the tension headache, it looks like a band around their head. So basically, there are 4 phases of migraine. It starts with prodrome, followed by the aura, then the pain itself, and then followed by the postdrome here. Now, the aura doesn't happen in all patients. It mainly happens in what we call classic migraine. But in fact, common migraine, the patients don't have aura. The aura is basically a visual and auditory manifestation to the patient, a very classic, and it lasts somewhere between 5 to 60 minutes. What causes migraines? They're multifactorial, like allergic reactions, physical or emotional. All of these changes in sleep patterns, smoking, hormonal changes, changes in routine, all of these are causes of migraine headache, hypoglycemia. These are triggers to migraines. The other condition, which is pretty rare, but we see them in the pain clinic, is what we call trigeminal autonomic cephalgias. Basically, these patients, they have basically small pupils, swollen or droopy eyes, reddened conjunctiva, tearing, nasal discharge or congestion, which are all basically signs of autonomic symptoms. And their main 3 types are the cluster headache, paroxysmal hemicrania, and another syndrome called the sun. Chronic daily headache is a headache that basically occurs in more than 15 days per month. Most of these patients are either chronic tension headache or chronic migraineurs that transformed to chronic daily headache. Another type of headache is sinus headache. And if you think about it, a lot of these sinus headache patients are diagnosed as sinusitis. In fact, they are migraineurs. And that's why you need to kind of differentiate between sinus headache and a migraine attack, because they can be really confusing to the clinician. What is the differences? A migraine attack usually goes away within few hours, up to 3 days. You may feel nauseous. With sinusitis, it will last you for days or weeks, and you will feel sick, though probably not nauseous. Other symptoms for sinusitis include fever, yellowish or greenish mucus, cough, and sore throat. I put this slide in the presentation because I wanted to explain to you what is the WHO analgesic letter. This letter was put forward for chronic and cancer pain, okay? And as you can see, it starts with a non-opioid, with or without an adjuvant, And then step 2, you add a weak opioid, such as codeine or tramadol. And then step 3, you add a stronger opioid. Now, we still use this WHO analgesic letter for non-cancer pain, again for chronic conditions. However, if you have an acute pain crisis, you cannot use this ladder from bottom to above. You have to go from the top to bottom. So in acute pain crisis, we start with the strong opioid. We do this all the time in the ER. So we're going to talk quickly about 4 of the most popular medicines for migraine, such as the acetaminophen, or what we call paracetamol, non-steroidal anti-inflammatory drugs, triptan, and drugs for nausea. We're going to highlight, basically on the NSAIDs in our presentation. So this is a famous slide. We know that these NSAIDs work on what we call cyclooxygenase enzyme. We have 2 types of enzyme. First one is COX-1 and the other one is COX-2. The COX-1 enzyme is the one basically important for protection of the gastric mucosa and hemostasis, while the COX-2 enzyme is the one that mediates the pain, inflammation, and fever. So as far as pain, we try to work on the COX-2 more than the COX-1, such as we have these selective drugs such as celecoxib, for example, that doesn't cause a lot of problems with the gastric mucosa because it's more selective on the COX-2. However, a drug like aspirin works on both limbs, COX-1 and COX-2. Again, the primary mechanism is the inhibition of prostaglandin synthesis through the cyclooxygenase pathway. We have the two COX enzymes, 1 and 2. The 1 is the one involved in the housekeeping functions, while 2 is the one mediating the inflammation. These are just some examples of famous NSAIDs around, such as aspirin, naproxen, ibuprofen, diclofenac, celecoxib, parecoxib, and in fact, acetaminophen is considered a special type of NSAIDs nowadays. Some of the side effects of NSAIDs could be serious. For example, it can cause urticaria or angioedema. So before you give the patient any prescription for NSAID, you have to ask them about allergic reactions in the past. Gastropathy is also very common, especially for patients above 60. Also, the patients are on steroids or taking alcohol on daily basis. Usually, when we give the patients NSAIDs, we usually give them some sort of a proton pump inhibitors, such as omeprazole, to protect their stomach. Renal impairment is also another problem with NSAIDs. I see it all the time in the clinic for patients are taking NSAIDs for months and months and years. I want to say that I stopped doing this practice, and I literally give the NSAIDs nowadays for short term only. And then I keep it as needed if the patient has a flare-up of his disease. The other problem is myocardial infarction. And this is related to the thromboembolic manifestations of NSAIDs. And also in these situations, I personally like to add aspirin, baby aspirin, to the NSAIDs if I'm planning to use it for long term. So I always ask the patient to take the baby aspirin in the morning, and 2 hours later, the patient can take the other medication, the NSAID, that's written for him. This protects this patient from having thromboembolic manifestations. This is a rare disorder called Stevens-Johnson syndrome. It's a medical emergency, and it can happen with many types of NSAIDs, including acetaminophen. If you see this, send the patient to the ER. One of the most famous medications that we use is a combination therapy in headaches, like paracetamol, codeine, and caffeine. This comes in so many names like solpadine and Fivadol and so forth. It's been shown that adding caffeine to the codeine and paracetamol actually makes the drug more potent. Paracetamol or acetaminophen is basically thought to cause selective cyclooxygenase 2 inhibition. The main problem with acetaminophen or paracetamol is the hepatic damage, especially if you use more than 4 grams per day. Or if you have a patient with liver disease or liver cirrhosis and you're using more than 2 grams a day, this might end with hepatic damage. And the treatment usually is what we call N-acetylcysteine, and it has to be given within the first 8 hours of the ingestion of the acetaminophen. This summarizes the acetaminophen metabolism: 50% by sulfation, 45% by glucuronidation, and only 5% is metabolized to what we call NAPQI. And this is the toxic metabolite of acetaminophen, and it can cause liver cell damage. Normally, we have something called glutathione in our body that basically binds to this metabolite and render it non-toxic product. The other drug in the combination therapy we just talked about is codeine. Codeine is a natural opiate, and it's a weak one. It's used mainly for mild to moderate pain. And we always use it in combination because of the additive effect with the paracetamol and caffeine. Codeine is metabolized in the body into morphine. The main problem with codeine is actually in Caucasians. These guys have deficiency, or at least 10% of them, they have deficiency of the enzyme that metabolizes codeine. And that's why codeine is not very famous in Europe and United States. Caffeine is another product. It's a methylxanthine that's known to act as a central nervous system stimulant. It has a wide range of physiologic effects, such as increased wakefulness, alertness, endurance, heart rate, and blood pressure, and is regarded as psychostimulant. It works on a receptor called the adenosine, A1 and A2A and A2B, with a lower affinity to A3. Adenosine works as a neuromodulator in your brain, especially at night. It helps dilate the blood vessels, probably ensuring good oxygenation to your brain during sleep. It's been shown in one study that if you give paracetamol 1 gram and you add it to caffeine 130 milligrams, is as effective as somatriptan in the treatment of migraine headaches. The International Association of the Study of Pain, which is basically the main body that puts all kind of nomenclature for pain syndromes, recommends actually simple analgesics like aspirin and paracetamol for the treatment of migraine attacks. And also, they suggest using compound analgesics such as those containing aspirin, paracetamol, and caffeine, because these have been shown to be more effective than single analgesics. However, they are thought to increase the risk of medication overuse headache. We're going to conclude this short presentation with the main things we talked about. Headaches are one of the most common problems presented to physicians. 47% of the adult population experiences headaches at least once per year. Primary headache constitutes 90% of cases. Tension headaches followed by migraines are the commonest types of primary headaches. Pharmacologic therapies remain the mainstay treatment in primary headaches. These are the references for my presentation. And thank you so much for listening to my lecture here, and have a good day.